Good morning, I'm Dr. Joe Mathew, and today I'm going to talk to you a little bit about jaw relations. At the outset, I want to tell you that this is not a comprehensive lecture. There's a lot you can talk about jaw relations, but this is a very basic lecture designed just for the undergraduate dental student to help him to understand this topic with clarity. Okay, so this is going to be focused really about the aspects of jaw relation that's going to be clinically applied at an undergraduate level. So this is a disclaimer I'm putting out there because don't be without reading your textbook. Go back home, read your textbook. You will find a lot of information I'm saying there, and you'll find some more information. Please use that as you study and as you answer for your exams. All right? So let's get into it. What is jaw relation? The relationship between the jaws is called jaw relation, obviously, right? So we have two jaws. We have the maxilla and the mandible, and the teeth usually provide the basis of the relationship between the maxilla and the mandible. So what happens is that when we don't have teeth, then everything starts to change and it gets difficult. So today's lecture is primarily going to be about jaw relation in edentulous conditions. But just before that, let me just tell you something so that you have an idea about dentulous conditions as well. Can every partially edentulous patient, he has some teeth, partially edentulous, do they need a jaw relation or do they not need a jaw relation? Because most of you are doing partially edentulous cases. So remember that in a partially edentulous situation like this one, when it's articulated, you could articulate it on an articulator without the need of a specific jaw relation, provided, or it depends upon the number of teeth present, the location of those teeth, and how they occlude or interdigitate with each other. So if you are able to have posterior vertical stops, that is posterior teeth occluding with other posterior teeth positively and definitively in the mouth, and you can see it and you can replicate it on your model, chances are that you would be able to mount the cast directly onto an articulator without any extra step of jaw relation. Okay, so that is the idea. In case there are no posterior stops, just the anterior teeth are remaining, chances are very high that you will need to do a jaw relation record or make a bite registration record. So in those cases where there are no posterior stops, you are going to follow the same techniques I'm going to describe for an edentulous patient. So there it's going to become the same. So remember that as we start this lecture, all right? So what are the prerequisites for jaw relation in an edentulous patient? It is a clinical step. For it to be done, we need to have what is called a record block. Don't worry about the word record block. Record block is basically the record base and the occlusal rim together. Some schools call them record blocks. Some schools just say occlusal rim. That's fine. Okay. So you have to prepare the record blocks, that is your record base and your occlusal rim, to the prescribed manner as has been taught to you in the preclinical lab. So if you are not going to do that, then you're going to spend a lot of time in the chair side trying to fix that occlusal rim. So the idea behind fabricating the occlusal rims to the prescribed guideline is so that your rims are near perfect, and when you place them in the patient's mouth, they require less adjustment to fit to the patient. Okay? And this will end up costing you less chairside time. I hope you understand what I'm saying. Because if you bring a poor occlusal rim from the lab, you're going to spend a lot more time in the chairside trying to adjust it to the patient's mouth. So what do we do first? We have a set of occlusal rims or record blocks from the lab that we've already fabricated, and we bring it to the chairside. We place it in the patient's mouth, and we are going to place each one separately, the maxilla separately, the mandible separately. And we are going to look through different aspects and we are going to adjust those rims to fit, to customize it, to fit that particular patient. Alright? This customization takes some time. So if our rims are poor, the customization is going to take a longer time. And this is where we lose our chairside time. This is the reason why we always require of you that you fabricate good rims to the good standards, the correct guidelines, so that they cost you less chairside time and the patient is not too tired. Alright? Okay, so as I told you, a record block is basically a record base and an occlusal limb. So there are some requirements for record bases, alright? And the record base needs to be a rigid material so that it can withstand the pressure that the patient is going to exert when he's trying to do the jaw relation. It needs to be an accurate fit in the mouth so that it is not wobbly, not unstable. The borders need to be similar to those of the finished denture or similar to the final impression that you made. This really helps because in such an event, the retention will be greatly enhanced. The support and the stability will be greatly enhanced. So the patient will be very, very confident in making the movement. Nothing is shaking. You are happy. The records are easy to record. The relations are easy to record. All tissue contacting areas must be rounded and polished. Now, if perchance there is an area in your record base that is sharp, the patient is going to shift his maxilla or mandible, trying to distance himself from the sore spot or the sore area where it's causing him pain. And this movement, knowingly or unknowingly, is going to end up creating a wrong jaw relation for you. And that's going to be expensive in the next appointment, right? So, materials in record-based construction are often temporary and permanent. Temporary record bases are those materials where you fabricate the record base and during the denture processing, right? Heat cure, acrylic denture processing, you're going to remove this and you're going to replace this temporary denture base with a permanent denture based resin. In a permanent denture based record, this record base is the first thing you're going to fabricate after you pour your master cast. That means you do the denture fabrication or you do the record base fabrication first. Once the record base fabricated, then the occlusal limb comes on it. Obviously, since this is the permanent record base, you are not going to remove this in the final processing. So if you're using a permanent record base, oftentimes you will have two processings. The first processing will be to fabricate the record base, the permanent record base. And the second processing is to fabricate the teeth portion and the wax portion of the denture. And in the second processing, you will not remove the record base because that is a permanent record base. So your new acrylic resin is going to adhere to the permanent record base in that situation. Alright. So what are the requirements for occlusal rim? The requirements for occlusal rim, they need to be made of a material easy to manipulate, obviously something like wax. Second, it needs to firmly attach to the record base. If the occlusal rim is going to move off from the record base, it's going to be very, very difficult. Some of you in the clinics, I'm sure, have experienced that. So that is something you don't want to have. It should be placed over the ridge and follow the form of the arch. If it's placed well over the ridge and follows the form of the arch, you will have a good aesthetic result. Okay? Remember that if one side of the mouth was, the extractions had been done, say 5 years back, and the other side was done recently, the resorption in this side will be way greater than the resorption on the other side. In such an event, your occlusal rim cannot be dished in on this side. It has to be harmonious and looking similar to both the sides so that you end up with a good aesthetic result. Okay. The labial surface of the upper rim should be around 10 millimeters from the incisor papilla. Also, it should be slightly proclined. And the mandibular labial portion should be vertical. Very important, never retroclined. Okay. Keep it vertical and then we'll adjust it to the patient's mouth. Alright. So there are 3 jaw relations that we want to talk about today. I'm not talking about how you adjust the record blocks in the patient, how you adjust the occlusal rim in the patient's mouth. Please refer to a video on jaw relations that I have put up. The clinical steps are there and you can see the 5 different things I'm looking for in my maxillary occlusal rim and in my mandibular occlusal rim. I look for them separately. I put the maxillary first, I check for 5 features, I find all of them, I'm happy, I remove it and put the mandibular in, look for the 5 features there. That you can check in another video completely. At this stage, presuming that you've done all that work, after you've done your adjustment of occlusal rim, then you enter into what is called the actual jaw relation. In the actual jaw relation, there are 3 different jaw relations: orientation relation, vertical relation, and horizontal relation, and they come in that order itself. You change the order, you end up with very poor I'm sorry, you changed the order, okay? Let me start off again. Jaw relations are three types: orientation relation, vertical relation, and horizontal relation. You change this order and you will end up with a mistake every time. So it's very important that you do not change the order of this. When you say it in the theory, when you write it in the exam, always mention it in the same order, just like you say 1, 2, 3, or like you say A, B, C, okay? Whatever it is, go in the same order. Alright, so just a quick word before we start the jaw relation itself. Let me just tell you about orientation of occlusal plane, because this is very critical. Even though it's part of the adjustment of upper occlusal rim and mandibular occlusal rims, it's very critical to understand this when we start our jaw relation, because if you don't orient your occlusal plane right, your jaw relations oftentimes tend to go wrong. So what is orientation of occlusal plane? Orientation of occlusal plane is that step where you are adjusting the occlusal plane with an instrument called the Fox plane. Use a Fox plane to adjust the occlusal plane of the maxilla, and you use a mandibular. You make sure that the plane is flat on a glass plate, and you make sure that it is evenly contacting the maxillary occlusal plane, which has been already oriented to the Fox plane. Now that is the orientation of occlusal plane. In orientation relation, it's the craniomandibular or craniomaxillary orientation. Okay, so to do this craniomaxillary or craniomandibular orientation, we use an instrument called the face bow. The face bow are two types. Okay, arbitrary, kinematic. The arbitrary face bow is usually fixed on the maxillary occlusal rim, and it usually has an entry point into your external auditory meatus. But when it comes to the kinematic face bow is usually fixed onto the mandibular and tries to approximate or identify the terminal hinge axis, or the actual rotating point of the condyle. So this is the difference between the two. In either case, when you have the face bow transfer is made from the patient. You record the orientation and you take out the face bow, and this face bow needs to go and attach to an articulator. Now you need a minimum of a semi-adjustable articulator onto which the face bow can attach. A mean value articulator does not support a face bow transfer. For this reason, you must know that it is not possible for us to transfer, since it's not possible for us to transfer the face bow record onto the articulator in a mean value articulator, it is not possible for us to do any sort of balance occlusion on a mean value articulator. So we have face bow transfer, we transfer it minimum to a semi-adjustable articulator, and then we can go on to do a balance occlusion. But in our mean value articulators, we cannot do a balance occlusion. So we are always doing a centric occlusion, oftentimes, in the mean value articulator. Okay? Like I told you before at the beginning, orientation of occlusal plane, we use Fox plane. Craniomandibular relation, we use face bow. So face bow for orientation relation, Fox plane for orientation of occlusal plane. Don't get the two mixed up. Alright, so this is the occlusal plane where the teeth are going to go. That's the occlusal plane on your record block, and we orient this to the interpupillary, right, and to the alar tragus. This is what is important. Alright, so for this the patient needs to be looking forward, and you need to be somewhere close to the front of the patient so that you can see where the interpupillary line is and you can make them parallel. If you're looking at it from the side, chances are very high that you will not get a right record. So make sure you are standing somewhere towards the front of the patient. So this is what a Fox plane looks like. This is what a Fox plane looks like, and this is the part that goes on to the maxillary occlusal rim. And as you hold it there, the Fox plane's two sides will extend out, and you will be able to record and to see the that's the anterior, and you'll be able to see the parallelism between the alar tragal line and your occlusal plane. Now, the alar tragal line is also called the campus plane, okay, and it starts from the ala of the nose and goes to the tragus of the ear. Usually you can take the middle of the tragus, the pointy part, the middle of the tragus as your guideline. There are certain guidelines that tell us variations with age and things like that, but as a general rule, take the middle of the tragus. Okay? Okay, once you have done your occlusal plane, you've corrected it to the interpupillary and to the campus plane, then you want to mark your midline and you want to mark your canine lines. The midline is marked to the midline of the face, remember that. Don't try to always look for the midline coinciding with the frenum. The frenum may be slightly shifted to the left or to the right. So make sure that it is coincident with the midline of the face. If you go with the frenum, as I told you, you might have a mild shift left or to the right, which will be very unpleasant for the patient when he smiles, he sees his teeth shifted off to a side. So make sure that this goes right through the center of the face and you can develop a great smile. Always also remember to mark your canine lines that can go from the inner canthus of the eye down running through your outer border of your ala, going down to your rim, or you can go through the corner of the mouth, depending upon what you deem is more aesthetic, and also it shows which aspect of the canine this line is really going to. Okay, so that's what's important: midline, canine line. Behind the canine line, everything needs to be straight so that you develop a beautiful buccal corridor, so the smile looks natural. You don't want to be able to see from one molar to the other molar. What is in the textbook described as a silver dollar coin appearance. You don't want that. That is not going to be aesthetic. You want to have a gradation and a curve. Next topic, vertical jaw dilation. So in vertical jaw dilation, obviously when the teeth are there, you can see they are deciding the location of the maxilla or the relation of the maxilla and the mandible. Once the teeth are lost, the maxilla and the mandible can come close to each other, can approximate each other, and chances are that you will have no idea where they are supposed to be. So in this situation, like here, the patient had teeth, look at the lower face height. And once he lost his teeth, look at how it goes. It decreases. The lower face height decreases and there seems to be a bursting appearance around his lip, right? All the folds become exaggerated, the mentolabial, the nasolabial, all of them seem to become exaggerated and the patient starts looking older. Now your objective is to open this up, give some facial fullness, lip support, visibility, open up this lost vertical dimension, bring it as close to the normal as possible. There are some factors that will not allow you to come all the way to how it was, but definitely you can come somewhere pretty close. Okay. One of the factors that will determine this to a good degree is the time of edentulousness. So if he's been edentulous for a long period of time, reaching from here back to here will be very difficult. But if it's recently edentulous, you can pretty much come very close to this. So vertical dimension, you have vertical dimension at rest and vertical dimension of occlusion. Now, in vertical dimension of rest, let me first tell you this. What we really need is a vertical dimension of occlusion, because that is how we are going to articulate on our articulator. And there is where we are going to arrange our teeth, in occlusion. We are not going to arrange our teeth with the freeway space there. We are going to get them into occlusion. So what we really need is a vertical dimension of occlusion. But we have no way to find that out because we don't have teeth. So we are going to go a roundabout way and we are going to find out the vertical dimension of rest. And then we are going to remove the freeway space or subtract the freeway space from that measure and to arrive at the vertical dimension of occlusion. One of the methods to do it. Okay? So vertical dimension of rest becomes very important in such a scenario. Alright, so we use facial measurements or measurements of correlated anatomic landmarks. So we take a nose, the point on the nose that is most prominent, we take a point on the chin that is most prominent, and we make a small mark on the nose and on the chin. Please don't make a mark that's very big like the Indian bindi, because if it's that big, there's no way you are going to be able to get an accurate reading. Remember that your reading will change. Your reading, the freeway space is about 2 millimeters to 4 millimeters. So if you've got a very large mark here that's already got a diameter of 2 to 3 for 4 millimeters, it's going to change every time you measure. So there's no way you're going to be accurate on that. So keep the mark as small as possible, and you can measure it either using calipers, a paper, or a Willis gauge. When you use calipers, please do not go ahead like this on a patient. Patient's going to get really scared, pointy instrument coming to his face. No, use it sideways, right? Use a paper or use Willis gauge. So there are different methods to help the patient, okay? He needs to come to a postural rest position, and that comes either from swallowing, shrug the shoulders, wipe his lips, swallow and close his mouth, makes the mandible assume a rest position. Tactile sense, ask the patient to open his mouth wide till his muscles are sore, and then relax it till he feels comfortable, again, rest position. Phonetics, patient is instructed to speak the words that contain the letter M, right? And then when the lips meet, when such words are pronounced, that is where the patient is asked to stop, and you measure that. So you can just use the letter M itself as yem, 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 and measure it. Or you can use a word that ends in M, because always Mississippi doesn't work. So you can use a word that's in your local vernacular language. You can use a name like Mariam, or you can use a word like Salam, or you can use a word that, any word that just ends in M sound, okay, an M sound. That'd be great. If it is sound, that'll be awesome. So that will really help. Facial expression. Have a good look around the patient's face to see if the muscles in and around the face are tight or if they are relaxed. If they are relaxed, then you can pretty much assume that he is in a rest position. Okay, when you use a Willis gauge, this is how you use it. Make sure that one end of the gauge under the nasal spine is outward and the other end is under the chin, okay? Not at the most prominent point. And of course, the scale needs to be facing you so that you can make the measure quickly. The Willis guide also states that the distance from the pupil of the eye to the rim of oris is going to be equal to the nasal spine and the bottom of the chin for vertical ambition rest. So this is interesting. So if you have this as a guideline, it can help you ascertain if what you have done is right or wrong and move towards what is right. Okay, so what is vertical ambition occlusion? I told you that's what we want. So vertical ambition occlusion, how do we get to it? See, I told you what we want is the vertical ambition occlusion. So as we know that when the teeth are clenched, we have what is the vertical ambition occlusion, and it will be easy, but since there are no teeth here, we are stuck, right? But we do know that when any patient sits, any dentulous patient sits normally, we know that there is a little space between the teeth when the patient is resting, when he's not clenching. There's a little space between the teeth. You can check it out for yourself right away, right? So there's a little space. Now that space is called the freeway space. So we know if we can measure the vertical ambition of rest and we can reduce this freeway space, we will arrive at the vertical ambition of occlusion. That is basically called Niswonger's method, and that is what we are going to use. So the interocclusal space is usually 2 to 4 millimeters, right? So that is the amount of play that we are going to have. We can either settle with 2, 3 or 4. We're going to determine that looking at other factors around the mouth and see if the patient is comfortable with the amount of freeway space we have granted him. Now this method is also called the Niswonger's method, where you have the vertical ambition of rest and you subtract the freeway space and you arrive at the vertical ambition of occlusion. A bit of a roundabout way, but an effective way. Okay, so are there other methods of measuring vertical ambition? Yes, the physiologic method, Niswonger's is one of them, and mechanical methods. So Niswonger's method is one of the physiological methods, and you have the swallowing threshold method, you have phonetics, you have neuromuscular perception, in which you use a central bearing point, or you can use Boo's power point, right? So there are these ways, and I told you Niswonger's is there. Swallowing threshold is where you use wax cones on the upper and lower denture and ask the patient to swallow and relax till finally no more wax is being displaced, and so you know that the patient is at rest right now. Phonetics is the closest speaking space, or the Silverman speaking space, where patient is able to speak clearly and the S sounds are very clear. Okay. Neuromuscular perception. Now it's amazing. You may not have thought of it that way, but the maximum bite force that you can put is usually at the vertical ambition of rest, and this was experimentally proved by Boo's and he called it the PowerPoint, not our Microsoft PowerPoint, but Bruce called it PowerPoint way back in 1940. He said that's the place where you can put the maximum bite force when you are at the close, very much at your vertical dimension of rest. So that is another way of finding out vertical dimension of rest. You have mechanical methods which involve ridge relations, right? The insulopapular to mandibular incisors relation, ridge parallelism. You have pre-extraction records that you can use, photographs, radiographs, old articulated casts, spatial measurements, all these things. So what is the importance of registering a proper vertical dimension of occlusion, or what happens if you don't register a good one? Well, if you have a high vertical dimension, it's way worse than if you have a low vertical dimension. Why? Because if you have a high vertical dimension, the patient is basically speaking like this, and he can't open his mouth because you have increased the vertical dimension too much. He's speaking like that, he can't open his mouth, you've increased his vertical dimension too much. Okay? So what happens? Inharmonious facial proportions, unnaturally separated and excessive display of teeth, right? Unnaturally separated lips, excessive display of teeth and denture base, difficulty in swallowing, loss of biting power, difficulty in speaking, clicking sounds when the patient is chewing or speaking, pain under the denture basal seat area, constant pain, ache, and it accelerates bone resorption, right? High vertical dimension. It also creates TMJ problems. So this is the big list of 9 problems, common problems you see when you have a high vertical dimension. A low vertical dimension, on the other hand, you have poor aesthetics, undesirable facial expression, always looking very sad, right? Flabbiness of the facial muscles not supported well. The teeth are not visible, doesn't look as though he has teeth, looks as though he doesn't have any teeth, right? Angular cheilitis, okay, and TMJ disorders. So it is not good to have an improper vertical dimension of occlusion, be it high or be it low. But if you're going to make a mistake, you'd rather make it on the side of being low slightly rather than being high, because high really will be disturbing to the patient. Okay? So, what are the factors that affect vertical dimension at rest? One, the posture of the patient. The patient should be sitting upright, not leaning back. A relaxed patient, the patient is stressed out, the patient is not going to give you a good rest position. Okay? Neuromuscular disturbance. Some patients have neuromuscular disturbance and they're not going to be able to give you a constant vertical dimension at rest. The duration, you can't go on forever trying to take a vertical dimension at rest record. So you have to do it quickly, and the longer time it takes, the more difficult for the patient to give you that rest position. Another key thing is use several methods. Don't just go with one. Use multiple methods. This will help ensure that you've got the right vertical dimension at rest. Then we finally come to horizontal relation. You have 2 relations, centric relation as well as eccentric relation. Right lateral, left lateral relation and protrusive relation are part of eccentric relations. But what is centric relation? Centric relation, you have a definition that is always updated in the GPT. I have not included that definition just because sometimes it's a bit confusing for the undergraduate students. So I'm going to stick with a very simple, old GPT definition just to make you understand. Please learn the other definition for your exam and for your viva, but just remember it's the most protruded relation of the mandible to the maxilla when the condyles are in their most posterior unstrained position in the glenoid fossa. It is from this position that they make their lateral movements, okay, at any given point of separation. So when we are talking about centric relation, we are talking about a point where the patient is not strained, and that becomes a starting point of every other movement, right? Now, centric occlusion is when you develop that occlusion, you're arranging teeth, creating occlusion. You develop the occlusion when the jaws are in the centric relation position. If you develop an occlusion at the centric relation, then that occlusion is called centric occlusion, all right? So, dentulous patients have something called maximum intercuspation position. This is the position where the teeth are interdigitating, and this is primarily governed by the proprioceptive mechanism of the periodontal ligament. Once the teeth are lost, that's gone. So our centriculation might coincide with the MIP location, but oftentimes it's slightly behind the MIP, slightly behind it, okay? So it may not coincide with the MIP. That's not a problem because we don't have the proprioception anymore, so we don't know where the MIP was, alright? What is the significance of centriculation? Centriculation is a bone-to-bone relation. That's the most important thing that you must remember. It's a bone-to-bone relation. It is guided by the muscles and the ligaments. So it's a repeatable position. Okay. Now this position, the first point is that it's a position that is functional even though it's fleeting in nature. Meaning it always comes back to that point and from there goes to every other position. Okay. But it comes there and then goes. Because it comes and then goes, it's called fleeting. But that is the reference from where it starts. Okay. The centriculation, because the bone-to-bone relation is guided by the muscles and the ligaments, so the patient can verify and repeat it even if he has lost the proprioception of the peroneal ligaments. The centriculation for any given vertical dimension remains the same for a long time. Okay, so that's very important, very interesting. And finally, centriculation is a starting point for developing any occlusion. I remember telling you that the jaw relations are orientation relation, vertical relation, and horizontal in that order. So if this is my maxilla and this is my mandible with the condyle there, for every given vertical dimension, you see there's a different horizontal because the maxilla is one, the mandible is one bone, it will move. Okay? So if you have this much opening, this is going to be the relation. If you have this much opening, this is going to be the relation. The horizontal is going to keep changing as you increase the opening or decrease it. This is why it's important to have a vertical dimension determined first before you do any horizontal relation. Don't think you can change it, don't interchange it, it will become a mess. Alright? Okay. So, like I said here, the relationship of the centriculation to the centric occlusion in complete dentures. What is the relationship? In complete denture patients, there are no teeth, so no MIP. Okay, there is no position that the patient can go to consistently except the centriculation position. So it's logically the best idea to develop our occlusion into the centriculation position so that the patient can come back to it as a starting point of occlusion. So what are the methods of registering this centric relation? You have wax registration methods, graphic tracing methods, terminal hinge axis methods, and tubing or function methods. So wax registration methods. Children refer to us as the nick and notch method or the notch and trough method. Most of the textbooks describe a notch development in the maxilla and a trough development, or how to develop a trough in the mandible, and then you record the jaw relation taking a bite registration into this position. So we all know that when we make the notches in the maxilla, they should not be parallel, but they should be divergent so that they don't slip and slide. And after that, in the trough of the mandible, we are going to place bite registration material and in the same coincident location and get the patient to bite. Once he is bitten it and the record is there, we're going to take it out and transfer it to an articulator, and you can see the notch is very clearly visible in the registration. So this way we know that because the notches are divergent, if it slips or slides, the material will break. So we know that the registration has not gone wrong, it is stable and you've transferred it to an articulator. Graphic tracing methods. Now graphic tracing, there are two types, extraoral and intraoral. The extraoral, you have tracers that go onto the occlusal rim. So one tracer goes onto the maxillary, one tracer goes onto the mandibular occlusal rim, and you put it into the patient's mouth. The pin is outside, that's why it's an extraoral tracer, and the table is also outside, and then as the patient does the movement, you end up with the arrowhead. Okay? See, the arrowhead, the head of the arrow is always the centric relation point. That's what you need to remember. Okay? And the one that's going straight behind the arrowhead is going to be your protrusive. But what we really need is a centric relation point here. Alright? Once you determine that, once you've got a very specific arrowhead, you want to lock the pin in that arrowhead position, and you can inject some bite registration material, whatever it is, and get that record and transfer it to an articulator. Now you can have extraoral tracers and you can have intraoral tracers. Alright? So the next one, I'm going to show you an intraoral tracer. So this is an intraoral tracer where the pin is in this case on the maxilla. Some people have pin on the mandible. Now if you keep it on the maxilla or the mandible, you will still get an arrowhead, and the head of the arrowhead will be, or the point of the arrowhead will be the centric relation record point, okay? But remember that if you change the stylus, if it's coming from the maxilla to the mandible and drawing on the mandibular base, and if it's going from the mandible to the maxilla and drawing on the maxilla, the arrowhead direction will change. That is not a concern. That is not a concern. What is important to us is that there is an arrowhead, and the arrowhead, head of that arrow, is our centric relation point. So here you have it like this. You have the stylus drawing and you get the arrowhead, and once you get the arrowhead, you locate and lock that position, and then you inject your registration material, take it out, and you can articulate it. Okay? So remember this, whether it's intraoral or extraoral, the head of the arrow shows the centric relation location. Terminal hinge axis method. I talked to you about phase bow. I said that there's a kinematic phase bow that is attached to the mandible and tries to locate or approximate the terminal hinge axis, or that point from where the mandible actually rotates. If you can locate that, then you can locate the position of the mandible from the opening, and that will reasonably give you the centric relation point. So chew-in or functional method. This is a method where the patient is asked to simulate chewing action, and records are made in wax to identify the centric relation. So Stansbury described it, Wicks described one, Sherry had his own technique, and Rudd has also given his own technique. All of them involve wax chewing in, and usually some acrylic fins and things like that, where the patient is asked to simulate chewing motion, and finally they are able to identify where the centric relation position is. Okay, and that gives us the chew-in or functional method of how to determine the centric relation. So we have talked about orientation relation, we have talked about vertical relation, we have talked about factors that affect vertical relation, we have talked about how to record vertical relation, we have talked about horizontal relation, we talked about the factors that affect that, and we have talked about the different methods by which we can record the horizontal relation. So I hope it's clear. You can go back and go through it multiple times. If you have any doubts, you can also contact me if you have any doubts, and I'll try to answer and help you as much as I can. So very simply, this is the adjunct lecture, and thank you so much.